Hello and welcome to a special interview for The Wire supported by Gagandeep Books. Today I want to discuss three critical but connected subjects. As India approaches the festive season, what is the big COVID picture facing the country? Could India face a third wave, or is that very difficult to predict? And thirdly, do we need booster vaccinations? Those are the three key issues I shall raise today with Professor of Virology at the Christian Medical College in Vellore and a member of the COVID working group, Professor Gagandeep Kang. Professor Kang, let's start with how you view the overall COVID-19 picture. The 7-day average of daily cases on the 2nd of September was 43,000. It fell to 37,000 by the 9th and further to 31,000 by the 16th. That means during the last 2 weeks, it's steadily fallen, and in the last week alone, it's declined by 16%. How do you read that?
I think one of the things that we need to be aware of is wherever we look at what's happened with the Delta variant when it's come into the country, is that after the sharp spike is over, things have not yet returned to what was the lowest point pre-Delta. So while our trajectory is good at the moment, whether it will fall to the kinds of levels that we saw in January this year or not, at least current data from other parts of the world does not seem to predict that that is likely to happen, but we will need to wait and see. If it does, that will be excellent, but it doesn't mean that we stop being watchful.
This is interesting. What you're suggesting is that the trajectory is good and it is slowly diminishing, but it's nowhere near the pre-Delta levels. Does that suggest that we may start plateauing at a particular level around 35,000 a day?
I think if we plateau at all. So the question really is, we've had a lot of discussion over the last couple of months where rates were low in many parts of the country. And the high rates that we saw, which are falling now, were driven by larger numbers of cases in Kerala, in the Northeast, in Maharashtra. So very specific locations driving the national numbers. I think that is the kind of pattern that we are more likely to see in the future, that within this large national number, there will be a fair amount of variation in the number of cases that come from different places. And these will be driven by the types of viruses that are circulating there, the vaccinated or infected population, and the behavior of the populations therein.
Let me pick up on that point. You're saying that we're likely to see specific locations rather than a nationwide picture of ups and downs. In other words, we'd have regional and local spikes, but not necessarily a nationwide massive spike. Have I understood that correctly?
I think in the absence of completely new variants that can escape the immune response that is induced by vaccination or infection, I think that is the pattern that we are likely to see.
This is very similar to what the chief scientist of the WHO, Professor Soumya Swaminathan, said to me on the 23rd of August. She said that given the high levels of seropositivity, 68% on average for the country as a whole, and the fact that we're now approaching something like 63% of the adult population having had at least one jab, she believed that India could be entering some sort of stage of endemicity. And she then went on to say that we would see local and regional ups and downs, but not a massive wave. And then to my surprise, I noticed that 2 days ago, Dr. Sujit Kumar Singh, the director of the National Center for Disease Control, said something very similar to NDTV. Do you agree with their views? Do you think this is the likely nature of what will happen hereafter, some sort of endemicity with local regional spikes?
I always add the caveat of variants, because this is an RNA virus that is replicating at very high levels around the world. decreasing, but still high levels. So the possibility of a new variant arising, either because of mutations, which is what has driven the new strains of the virus largely so far, or because of a form of combination called recombination, we always have the danger of variants arising. Now, if those variants acquire the characteristics that allow them to overcome the immune response, the patterns will change. In the absence of that, or in the presence of just mutations, I think the patterns that have been described by Dr. Soumya Swaminathan and Dr. Singh are the ones that we are likely to see in the future.
Okay, that leads to a connected question, Professor Kang. In that case, what do you make of the fear, and it is only a fear, that India is likely to see a third wave? And it's been said by many people on television, sometimes it's been said by the government, and in fact, to be honest, the chief epidemiologist of the ICMR in the middle of July said we would have a third wave starting in August, which would peak in October, and we're now already into the middle of September, and that third wave hasn't happened. So what do you make of these fears and predictions of a third wave? Are they credible, or do you align yourself with Dr. Swaminathan's view that it's impossible to predict a third wave because no one has a crystal ball?
I don't think we can predict a third wave in the absence of very radical viral behavior change or human behavior change. One way to think about a third wave is if you took all of the people that have not been infected or vaccinated so far, put them in one place, your likelihood of a third wave goes up. That's unlikely to happen. So I don't think that in the absence of the virus changing, we will see a third wave that is anything like the second wave.
That's very clear, but I'm just repeating it so that people can understand in simple English. What you're saying is, in the absence of a drastic change in the virus or in the absence of a major change in human behavior, we're not likely to see a third wave, anything like the second wave we went through a few months ago. Is that okay? Is that the right way of putting it?
Absolutely.
But that also means that the fear or apprehension, as well as the comments made on TV by various experts, are somewhat unwarranted at this point of time.
I really don't know what they are basing their comments on. The scientific evidence seems to support the stance that Dr. Swaminathan and I are taking.
Let's briefly turn to Kerala, which is a state that worried people several weeks ago. Today, the picture in Kerala is very similar to the national picture that I discussed at the very start of this interview. The 7-day average of daily cases in Kerala was almost 30,000 on the 2nd. It fell to 27,000 on the 9th. It fell below 20,000 to 19,500 on the 16th. So even Kerala for the last 2 weeks has been steadily declining. And here I note that the percentage decline in the last week was over 25%. Do you get the feeling Kerala is turning a corner, or is that a little hasty?
I think Kerala is doing very well with its vaccination program, and my understanding is that the center has allocated extra vaccines to Kerala in order for them to be able to ramp up their vaccination. So now that they are approaching the national average in terms of the number of people who have been infected or vaccinated, they are in a very similar position to the rest of the country, which is to have a large proportion of their population no longer susceptible to severe disease or to hospitalizations. We have to remember that infections will continue to happen even among previously infected and vaccinated individuals, however, at lower rates.
I understand the point you're making, that in fact, Kerala's vulnerability, because its seropositivity was so low compared to the rest of India, is now changing because vaccination is so much higher And therefore, as a result of vaccination, Kerala is less vulnerable than it was earlier. And therefore, the number of vulnerable people the virus can attack has diminished. But coming back to this declining trend of daily cases in Kerala, how do you read that? Because whilst there's no doubt that for the week ending the 16th, cases came down by 25%, in the last 2 days, they've crept up again above 20% to 22,000 levels. So how do you read this?
I think you're going to see some bounce that is dependent on testing behavior, on what is happening in the state at the time. You can't expect a trajectory to be maintained day after day. So I really prefer the weekly moving averages to looking at individual days if we are to look at patterns. So 2 days data wouldn't bother me too much. 2 weeks data certainly would.
In which case, how do you respond to a note of caution raised by Professor Rijo John? He says there's no doubt that cases in Kerala are declining by 20%, but testing has also declined by 10%. Does that suggest that some of the decline in cases is not real, but a result of lower testing? Or do you take comfort from the fact that over this period, the test positivity rate in Kerala has also gone down by 2%?
I think the fact that the test positivity rate has gone down is a positive indicator that public health authorities are doing their job. The question that I really have about testing and the level of testing that we have and the strategy that we have for testing is, don't we need to change now? What we are doing today is what we started to do 18 months ago. It evolved with time, but it's evolved keeping the same framework that we had for public health control. Is this still a time to be testing, tracing, and isolating every individual who has tested positive? Do we need to be looking at circumstances? Should we be looking at, does every RT-PCR that has a value of above 35 really need isolation and contact tracing? I think the time has come where we need to be thinking about what the future of control of SARS-CoV-2 should look like, what our strategies should be, and what our trigger points should be for initiating greater testing or thinking about isolation or the kind of approaches that governments have taken to restrict movements of individuals.
So you're suggesting in that answer that the 10% decline in testing in Kerala is not laxity, but a deliberate attempt to rethink the utility of testing and to change the intent and purpose behind testing, because one can't carry on the way one did from the start of the pandemic. Is that what you're suggesting?
So I don't know why Kerala has decreased testing, but I think as states and as a country, and in terms of what the rest of the world is doing, I think the time has really come to not treat SARS-CoV-2 the same way that we treated it at the beginning of the pandemic. And unfortunately, very few places have begun to make that change. What is fit for purpose surveillance when a community has 65% seropositivity and immunization adding on top of that? What really are you looking for as your public health goals? What are you looking at for your healthcare system goals? We have to recognize that an emphasis on SARS-CoV-2 means also a neglect of many other things that are required to maintain the health of our populations and to treat those who are sick. What's the trade-off? We can focus all our efforts on SARS-CoV-2 to the detriment of all things, or we can come up with a new strategy that gives SARS-CoV-2 the importance that it deserves, but does not focus on that to the exclusion of all else.
Now, if I understand correctly, you're not just saying that we need to change the intent and purpose and nature of our testing, but we also need to put SARS-CoV-2 in a perspective so that it doesn't dominate our concerns, and we find a way of paying sufficient and adequate attention to all the other health concerns that perhaps have been forgotten for the last 18 months. In other words, we need to balance the way in which we treat SARS-CoV-2 with all the other health issues. Is that right?
Absolutely.
In terms of that rebalancing and rethinking, are there other issues that you'd like to mention that we should pay attention to?
I think we need to recognize how much people have suffered during the last 20 months of the pandemic. Because in terms of health, we have more and more indicators that maternal outcomes during pregnancy have been worse. People with cancer haven't gotten treatment. A lot of people with diabetes didn't get their drugs. What is this going to mean for tuberculosis control when people were unable to access their treatment for months at a time? I think we need to take stock of the damage that has been done and make sure that we build systems that try to address that damage, but are also more resilient for the future.
One quick question on this before I move on. I assume that one of the reasons why you believe the time has come for this sort of rebalancing and putting SARS-CoV-2 in a proper perspective and not letting it dominate our thinking is because you also believe, as Professor Swaminathan said, that we could be reaching some sort of endemicity, and the chances of a frightening third wave like the second are not very large. And that's another reason why the time has come to start rebalancing and rethinking.
So I think the fact that a large proportion of our population is now immune, not to infection, but at least to severe disease, is a time when we need to rethink what the future will look like. There is, I think a lot of people misunderstand what endemic really means. And I'd give you the example of typhoid, a disease that continues to be prevalent in India. You do see outbreaks of typhoid that can be food or water driven, or sometimes we don't really find a cause, but we know how to handle it. We've lived with it for centuries. Now, are there things we could do better? Yes, absolutely. Do we have the resources to do them? I think that is policy that the government needs to be thinking about. And for SARS-CoV-2, also, we need to be thinking about, we're doing all of this in the short term. This is practically a standalone problem. But the people that are being affected by SARS-CoV-2 are not affected only by SARS-CoV-2. So if we think of the health ecosystem as a whole, if we think of society as a whole, I think we need a balancing act.
Absolutely. And we now need to begin to think of SARS-CoV-2 like any other endemic disease that affects us. And you took the example of typhoid. We know why it happens. We know what to do. We can do better. In a way, our attitude to SARS-CoV-2 should be similar to the way we handle typhoid.
Good.
Okay. And that's an agreement from you, isn't it? Just to be sure.
Well, I'm kind of hoping that the government will think about typhoid vaccines. It seems ridiculous that yesterday in the New England Journal of Medicine, there was a paper from Malawi that talked about an efficacy trial with an Indian-made vaccine, and typhoid vaccines are being introduced in many other countries, but not ours.
Okay, that's very clear. We need to think of SARS-CoV-2 a bit like we think of typhoid. It's there. We know how to handle it. We can do better. We should find ways of doing better, but it mustn't any longer dominate our health concerns. There are other issues that matter as well. We must pay attention to them. Let's then come with that in the background to another issue of concern, which is vaccinations. I know we did a terrific job yesterday on Mr. Modi's birthday. We vaccinated more than 25 million in a day, and it may well be an international record. But the truth is, overall, only 63% of India's adult population has received one jab, and only 21% have got two. And therefore, the question I ask is this: it's increasingly becoming clear, if not indisputable, that we're not going to make the government's target of fully vaccinating every adult by the end of the year. We will fall short. How much of a concern is that? Or is it not such a big concern because seropositivity levels have given a degree of comfort and assurance, as well as the fact that it does look that the disease is becoming endemic and we won't see hideous spikes again?
Well, if you look at targets, a target is something that the government came up with. They came up with dates, they made predictions on how much vaccine there would be available, and it doesn't look like they're going to meet the target. Is that the end of the world? It really isn't. We're doing a good job with vaccination. Among middle-income countries, we've got really excellent vaccine coverage. We are rolling out vaccines as they become available. We are not wasting doses of vaccine, which is happening in countries in Africa. So I think we just need to keep at it. Every dose that comes out, we need to be making sure that it gets into an arm somewhere. Now, is this the time for us to be thinking about also opening up to share vaccines with the rest of the world? That is a strategy decision that I would leave to the government, I guess, and to the vaccine companies that have the agreements. But I don't think we are doing badly on vaccination. We will get adults covered. My question really is, are we covering the most vulnerable people at the right rates? And that is something that worries me. I think when we think of the over 60s, when we think about people with comorbidities who really need vaccines, what we need now is a metric that shows us that we are doing well on ensuring that they are protected. And what I've seen so far has not been particularly reassuring.
In that context, let me raise the question of whether we should be giving booster vaccines. Pfizer, a couple of days ago, has accepted that the efficacy of their vaccine, and it is commonly considered the most effective vaccine, diminishes and wanes over time. Pfizer has also accepted that the rate of breakthrough infections in vaccinated people is actually increasing, which is why countries like America, Britain, most of Europe, Israel, Canada are either beginning or considering booster jabs. Should India consider booster jabs specifically for the three categories you mentioned? People over 60, people with vulnerabilities because of their comorbidities, and perhaps healthcare workers who are at the very front line of risk. Should we consider booster jabs for them?
I don't think the time is right to consider booster jabs for anyone in the country at the moment, except potentially people who are immunocompromised for one or the other reason. We know from the data from the US, from Israel, from the UK, that efficacy against infection declines reasonably quickly. So within 6 to 8 months, you have a rapid decline in the efficacy against infection, and it's more for the Delta variant. The decline in efficacy against severe disease and mortality is much slower with these vaccines. Now, the question to me is really, what is the right time to give a booster? Am I saying we will never need to give a booster? Absolutely not. My questions are really, what is the right time for which population, and what is the right booster? And we don't really have answers to these questions at the moment. There is data that is emerging from the early vaccinators in other parts of the world, but not so much with the vaccines that we are using. There is some data that is coming from the AstraZeneca vaccine, and we absolutely should be tracking what is happening with that. But is 6 months the right time to boost? Is 12 months the right time to boost? Is 2 years the right time to boost? We don't really have answers for that. How much disease will be prevented by boosting? We don't really have an answer for that. So I think we need to make sure that we are set up to get those answers from the data that we have. And in our situation, with the high seropositivity rate, the data from the UK, Israel, and the US are not directly something that we can accept and use.
So
Then the other question.
So please carry on. Please carry on.
Which vaccine to boost with? Should we use the same vaccine we've had before? Should we use a different vaccine? There are data that are emerging that shows that mixing vaccines might give you a better primary response as well as a better boosting of response. If we need to know that, we need to do the studies, and the vaccine companies aren't going to do that.
So the bottom line is that this is not the right time to consider booster vaccines in India, except possibly, and this was the only exception you had, for people who are immunocompromised. They may be the only exception.
That's correct.
One other question, in a sense connected to this, but it is a different question. Is there a percentage level of adult vaccination at which you would say India can, with relative security, open up the way the UK has?
I don't think that there is a perfect number. All you can say is that the greater the vaccination rates, the more open you can be. But given that we are not vaccinating children as yet, and the age distribution in our population is very different, is skewed much younger, I don't think that even if we vaccinated every adult in the population, we would wind up in a situation that's exactly analogous to any other country. So these are decisions that we are going to have to make for ourselves. And that's why I think a future game plan for SARS-CoV-2 is an important thing for India to evolve. Whether it is testing or it is treatment or it is the kind of public interventions that are being made, we need to know what levels.
The last issue that I'll touch on, and I'll do it only briefly, is there are concerns that vaccination is not happening as smoothly in rural India, which is where the majority of the country's population lives, as we would want. Anurag Beher, the CEO of Azim Premji Foundation, said to me last week that he's been working with over 500 primary healthcare centers in rural and tribal districts across 12 states. And he's discovered that in 20% of cases, there's a shortage of vaccinators. And the bigger problem is that he says data handling has become the primary job rather than vaccination. And this is to do with such technical things as the slowness of the net, the difficulty of putting it up, electricity connections, etc. How worrying is this? Because if these problems are affecting effective vaccination for the majority of your population, it is a real concern, isn't it?
Well, I think one of the things that has been a problem throughout the pandemic is the amount of data that has been required to be collected by people who have anything to do with any aspect of the pandemic. The number of reports that they need to put in and the number of authorities that they are reporting to. Now, I certainly hope that those data are being well used, but I have my doubts, as I think all of us do. When it comes to the delivery of vaccination, in principle, the largest vaccination program that we have ever run requires that we have an ability to handle the data. And clearly, electronic data capture makes a lot of sense. But can you make electronic data work everywhere? And what are your backup strategies for that? We saw in the early days of vaccination that we had issues with language, we had issues with connectivity, we had issues with people not having smartphones, and these were addressed with time. Now, will there be an effort to make sure that there is offline documentation of vaccination in rural areas that does not consume too much time, that allows people to do their primary job of delivering vaccines. I think it happens in many states. I'm in Tamil Nadu, and the efforts that the government has made to reach out to rural and tribal areas, the kinds of partnerships and community strategies that have been developed have been pretty incredible. But it requires now for the states to commit to making sure that they identify where there are vaccine deserts and make sure that they get vaccines to those areas. One good thing, even though I didn't think so earlier, the fact, I had really wanted a strategy where you focused on the elderly first and then you came down by age strata, much like the UK had done. But in opening up to 18-year-olds and above, what we've essentially done is made it at least possible to have a geographic saturation strategy. Is that being effectively used? Is that being properly set up for by appropriate communication ahead of vaccination? That I'm not so sure about for many parts of the country.
One more issue I'll raise before I end, and again, it's one that Anurag Beher raised with me in an interview last week. And it's in a sense the opposite of what we're talking about. It's not too much bureaucratic paperwork and filing of data, which is slowing down vaccination. It's that we don't require people in rural India or even urban India to give their addresses. As a result of which, he says, we don't have an effective way of contacting people who came for their first jab but haven't returned for the second. And we have no way at all, it seems, of contacting people who haven't shown up at all. And to rely on their phones is very difficult because in rural India, connectivity is poor, the numbers are often wrong, or people don't respond. And as a result, he says, and I'm quoting him, we may soon be awash with vaccine supplies, but we will not know who these have to be delivered to, when and where, and how to make it happen. That's the exact opposite of the problem we began with when we had a shortage of vaccines. Now we could have too many, and because we don't have addresses, we won't know who to give it to.
I think it is a very serious issue in rural India. When you ask the government, they say that the bulk of our jabs are being given in rural areas, more than in the urban areas. But when you actually ask for data that breaks down what are the areas in which coverage is good or bad, then it becomes more of a problem to get that granular information. And what Anurag is referring to is places that I'm calling vaccine deserts, places where you can't get the vaccine because you don't know, you don't have a relationship with those communities. You don't know how to access them, and you haven't done the right communication. So there's always a push factor from government, but what you really need for good vaccine coverage is a pull factor from the community that wants to be vaccinated. Well, if they don't know about it, if they are misinformed, if they are the recipients of disinformation, there is going to be no pull factor. And we need to focus, if we want high coverage, on addressing that as quickly as possible.
These are the people that traditionally and historically are left out and even, I would say, forgotten by the Indian system. And it seems once again that's happening. And that means that not only will we fail to vaccinate every adult, but we will leave behind large cohorts where the virus can continue to spread and, God forbid, mutate. And so despite the high levels of vaccine in percentage terms, these unvaccinated cohorts will remain a danger to the rest of the country and to the world thereafter.
Danger to the world is a bit extreme because some of them might have vaccine infection introduced, and then the infection will spread in that population. But I think coming back to the vaccination story, we should look at what happens with routine immunization, which is immunization of children built over decades of effort by the government. And there, with intense efforts, routine immunization, periodic intensification of routine immunization, Mission Indradhanush, intensified Mission Indradhanush, we managed to reach 90% of all children. And these are children, right? born largely in facilities with documentation, with special workers knowing where they live. And we managed to reach 90% immunization. Now, when you begin to talk about adult populations where you don't have records, then the size of the problem is something that we should anticipate and work towards addressing.
And this is therefore the task the government faces, which it must give more attention to. Is that also something you would add?
Oh, absolutely.
Because if it doesn't, we will not only fail to vaccinate the entire country, but we will leave areas where the virus will continue to spread.
Well, again, if infection has not gotten into those areas
already. Absolutely. Thank you very much for this interview, Professor Kang. You've given us the tour d'horizon of the actual picture facing the country today. More importantly, you've agreed with Professor Soumya Swaminathan and Dr. Sujit Kumar Singh that we could be reaching some sort of stage of endemicity, provided there are no new worrying variants that happen. But in the absence of that, and in the absence of any major change in human behavior, we will see ups and downs locally and regionally, but not another spike like the second spike, which terrified the country. And then finally, you believe, with the exception of those who are immunocompromised, India should not consider booster vaccines for anyone, because we simply have not worked out how it is to be done, where it is to be done, with what vaccine, and in what way. I thank you for this, because I think you've answered many issues and concerns that people were discussing. Take care, stay safe.
Thank you.